today we will be discussing about the pediatrics component of the PGDMCH program, that is IMNCI 103. Today for discussion of this we have three experts. To my right, Professor A.K. Agarwal. He is the Director, School of Health Sciences, and he is coordinating the above all program in the school. To his right, Professor M.S. Prasad. He is Professor and Head of the Department of Pediatrics in Safdarjung Hospital. He is also our program in charge and a counselor for pediatrics component. To the extreme right, Dr. Harish Chalani. He is Senior Consultant in Pediatrics and he is also an IMCI expert, and he is involved in our program as a counselor and also as a course writer. Now I will request Professor Agarwal to welcome the students and the delegates.
With regard to the PGDMCH program has got the component of three subjects, that is the pediatrics, the obstetrics and gynecology, and the community medicine. And the pediatric component has undergone major revision by incorporating the IMCI into its discussions. Now, why the IMCI, the integrated management of childhood illness, was required to be incorporated? You see, if you look at the 0 to 5 morbidity and mortality, the mortality particularly in the developing world, more than 10.5 million deaths are taking place every year on account of 5 major illnesses, and these 5 major problems are pneumonia, then diarrhea, fever including measles and malaria, malnutrition, and certain other problems like ear infections and these things. And these lead to 10.5 million deaths annually in the developing world. Then because these are very killer diseases, but also very simple to prevent and also very simple to treat and control. Therefore, the WHO and UNICEF jointly in mid-90s onwards, they developed a strategy to control these 5 serious killer problems through a algorithm-based, evidence-based medicine, or the pediatric medicine to control these 5 diseases. And what is more important is that the malnutrition is cutting across nearly 2/3 of these problems. So malnutrition is common to all these 5 problems which we narrated, and the malnutrition becomes therefore in developing world very, very important to control. And if we can control the malnutrition, probably we can also increase the resistance in the body, and thereby also control the mortality, and probably the morbidity conditions will be only prevailing to some extent. So at this juncture, viewers, I would like to also welcome a delegation which has especially come to witness this teleconferencing from Norway. The Norwegian government has sent a delegation of about 30 doctors, nurses, health professionals, health economists, etc., who are participating in the hospital administration program there in their country. And this delegation has been received by Dr. Y.P. Bhatia, who is the medical administrator and director of the Rajiv Gandhi Cancer Hospital. And you can see that they have specially come here to witness how through distance education we can through interactive teleconferencing, as we do every month for this program, how we can make it more meaningful, and virtual classroom is created through your interactions.
I will request now Professor Prasad to give a highlight of the development of IMCI and its implementation in India.
The question comes that why this IMNCI or IMCI, and what after all it is. In fact, the full form of IMNCI is Integrated Management of Neonatal and Childhood Illness. Let us talk about IMCI, which is the precursor of the IMCI. Why IMCI came into existence? Well, if we see the global burden of the diseases, maximum diseases, they are borne by children under 5 years of age. There are 4 examples given over here. It is ARI, that is pneumonia, diarrhea, measles and malaria. We will find that maximum is covered by children under 5 years of age, to the extent that measles up to 89% patients, they are under 5 years of age. It means that is a vulnerable group which we have to tackle with. So the current scenario, as already has been told by Dr. Agrawal, that more than 10 million deaths are occurring every year of under 5 children, and mostly these deaths are because of the pneumonia, diarrhea, measles, malaria, and of course malnutrition is almost in the 54% of the cases they are associated with that. And you know that malnutrition makes any illness worse than when that illness occurs in the normal children. And so if we look into the causes of the mortality and morbidity, as I already told, and Professor Agrawal also told, that pneumonia, diarrhea, malaria, measles and malnutrition, these are the major mortality under 5 years of the age. And morbidity, patients do come with cough, diarrhea, fever, and then feeding problem and malnutrition. These are the major morbidities. There is a study done in Bangladesh, in Matlab Thana. This is very interesting slide. Usually patients come with one symptom, doctor in habit of writing one medicine for one symptom. But if you see this slide, patient under 5 years of age, only 15% of the cases they had one symptom. Rest of the patients, that is approximately 85% of the patients, they had more than one symptom. I am surprised that 0.7% was that patient which has 20 symptoms. That is quite surprising anyway. But so to say that many children, they come with many symptoms. So we have to have some approach which can cover maximum symptom and giving the maximum benefit with minimum intervention, with minimum expenditure, with minimum utilization of our resources. So you see that if we go through our current practices without IMCI, by the next 20 years, I will find that hardly there is a reduction of the 3% from 55 to 52%. It is nothing. So there is some intervention required. What is that intervention? Let us see. So this I understand. Millennium Development Goal is picturized over here, and the red line shows that with the current scenario, we can achieve hardly up to 55 or 70. And our goal is to reach below this by the year 2015. So the gap between this has to be covered. Now this gap has to be covered by some strategy, and IMCI is that strategy which can cover this gap. There are some inadequacies in our health system that has to be covered. First, the health workers' skills are incomplete. They do incomplete examination of the patient, and counseling is very important point. Counseling is either half-heartedly done or not done at all. Then there is poor communication between the health worker and the parents, and sometimes the use of drugs are not rational. They have got irrational use of the drugs. That is the health workers' skill deficiency. Then there is some issues in the health system also. The location of the health service facility and its access is difficult. Then in the health system, the availability of the drugs and vaccines are also a problem. And of course, over and all, a perfect organization and a perfect supervision of the health system has to be improved. Then there is some inadequacies in the community and family practices also, like they do not seek the health care immediately, they delay unnecessarily, and that makes the patient's condition worse. Then they have got poor knowledge where to go, and when to come back to the health facility. Once seen by the doctor or the health worker, when they have to come back, this they have got poor knowledge. There are programs like for management of the diarrhea, we have got programs like control of diarrheal diseases, CDD, and oral rehydration therapy, ORT program. For management of the ARI, we have got ARI management program, ARI control program. For immunization, we have got extended program of immunization and universal immunization program. For nutrition, we have got nutritional program. But these are vertical separate programs, time-tested interventions. They are perfect, but they stand separately from each other. There is no coordination, there is no integration. So the IMCI, that is the integrated management of the childhood illness, that makes an integration of these all programs. And you will see that this yellow triangle which is representing this IMCI is the broadest at the square where it is management of the sick children, then nutrition, then immunization, and gradually tapering over to the other disease prevention and promotion of growth and development. So our doctors and health workers and healthcare providers, they will think that yet another program has come, like prevention of blindness and prevention of anemia. No, this is not another program. This is a strategy, this is a time tested strategy, this has got high specificity and sensitivity, and this is an approach, and this strengthens our existing health system. So those three inadequacies which just now I have described, this IMCI covers it very well. Now IMCI, when it was implemented in India, we asked certain questions. Is it feasible in our country? Is it a requirement of our country? And can we implement it? And answer is yes. IMCI is very much relevant to our country because it addresses all the three inadequacies, and it can improve the condition of the baby children under 5 years of the age. You will see in this last slide which Dr. Jaina was showing, that distance learning. Here is the IGNU plays its role by calculating this IMCI in the PGDMCH course. Through distance learning, this is being implemented in India. Computer based education is also being under process, which will be implemented very soon. I think this is the background why IMNCI has been adopted in India. And one more thing I would like to add, that in India we have included the home visits also. When the child is born, the Anganwadi worker, who is also a health worker, she visits the newborn and the mother on the first day, and then subsequently on third and seventh day another home visits are made. And this is unique thing for the India, which has not been done elsewhere in the world, though this IMCI has been implemented more than 108 countries in the world. But in India, this home visits are unique thing, and this is a very successful thing.
Thank you, Dr. Prasad. Now, you have already listened that why IGNU accepted this IMCI approach in its curriculum. Now, keeping this in mind, the next step will be what is the process, what this IMCI process is. I will request Professor Agarwal to highlight some of these processes.
Thank you, Dr. Jaina. The 0 to 5 group has been divided into two groups, and that is 2 months up to 5 years. That is the sick young child. And then the first, of course, we should say young infant. The young infant is 0 to up to 2 months. That is we call the sick young infant, including the neonate period, that is the newborn up to 2 months of age. So the whole IMCI focuses in these two categories by dividing the children or the 0 to 5 age group into two specific groups for definite reasons, because the 0 to up to 2 months, that is the sick young infant, needs a particular very specific attention for those killer serious bacterial infections, jaundice and other problems which you will be discussing and seeing in the process. And then we have the sick young child, that is 2 months up to 5 years. And you know, there are some steps. The case management process, how we divide, if you see the chart book, the whole process, as we said, is the algorithm, evidence based. So these are the steps: assess the child, classify the illness, identify treatment, treat the child, and then last two are the most important in IMCI: counsel the mother. The counseling of the mother and the follow-up care are the backbone of the IMCI process, or involved in the IMCI. Further, the materials required. You see, we have the case recording forms for young infants up to 2 months of age, and then for older children, and that is we call 2 months up to 5 years. So there are separate recording forms, and these recording forms describe all the process. You have to simply assess, classify and treat the child according to the inventory of the items given in these recording forms. Then we have the chart book, and then chart book is like a Bible for pediatrics, and that chart book should be always with you when you are going to the hospital to practice the IMCI. So we select the appropriate section for this, whether it is young infant or the older child, and then accordingly chart book will help you. The assess the child, only 3-4 important questions that you as doctors or health workers should ask, and these 4 important questions or things are: ask the mother what the child's problem is, then look, you know, looking and seeing the child can give lot of information. Ask, look, listen with respect to maybe respiratory sounds, listen to the complaints of the mother, and then feel the child. So ask, look, listen and feel, these are the 4 basic things where you have to concentrate while you are managing the IMCI process.
Okay. Thank you, Professor Agarwal. Now the next step is to highlight that how to communicate with the mother. I will request Dr. Prasad to highlight these few components.
Counseling the mother will be successful only if the health worker or the doctor, we are all health worker, even the doctors are pediatricians are also health worker. All those persons who provide health care to the patients are health worker. So if we have good communication with the patient's attendant, mostly this is mother, then the counseling will be good, then the implementation of the treatment or management, whatever we have decided, that will be most successful. Now, the good communication skill is required from the moment the patient contacts you first. And you know the patient, babies under 5 years of age, they are brought mostly by the mother. Sometimes father also brings, sometimes uncle or elder sister, elder brother also brings, but mostly this is the mother. So when the mother comes, the health worker, health care provider must greet the mother, offer a seat to the mother, and then seat should be at equal level to the mother as you are sitting. After greeting, you ask about the baby's problem. That opens question. Mother will feel that this doctor, this health care provider is going to give some care for the baby, and that starts the communication. That is the first step. Then when you ask the question, you must listen properly. When you ask the question, that should be asked in the language which mother understands. Mother may be feeling hesitant in giving the answer. You just encourage her in giving the answer. She may take some time in giving the answer. So please wait, she answers. And while you are listening to her answers, not only listen, but please appear to listen also. Like if somebody is talking to me and I am talking to somebody else on my mobile, that is not the correct. I must see at the mother that I am paying attention to her also. That is what the listening to the mother's answers. And whenever we ask about the child's problem, mother says, and we also ask that what mother is doing for the child, and whatever good things she is doing, we must praise that thing appropriately. If she is giving breastfeeding to the child, we must say you are doing very good thing that you are giving breastfeeding to the baby. And then after listening the problems and doing all these things, we must advise the mother. Again, that advice has to be in the language mother understands very well. A good advice is that advice which is shown by examples and which is also tested by observation. So if you remember how the surgeons, they learned surgery, they first observe their senior surgeons doing the surgery, then they do the surgery under supervision of their seniors, and lastly they are allowed to do the surgery themselves. Similarly here also, if you demonstrate how to measure a spoon of the medicine, then ask mother to show how to measure a spoon of the medicine. If you show the mother how to be given to the baby and ask the mother how to give, then that will have a great impact on the mother. So the home treatment which she is going to carry out at the home, she will do in much better way if these communication skills are done. And lastly, which is not a least point, before mother leaves your clinic, you must check the understanding of the mother. Whatever you have told, had she understood well? So you have to ask certain checking questions, that whatever you have done, there are good checking questions, there are bad checking questions. Now first, bad checking questions are those questions which have got answers only in yes and no. Suppose if I ask some lady, have you understood what I told? She says yes. Doesn't mean that she has understood or not, she just say yes. So there are questions we have to ask. Now when you have understood, tell me how many times you will give this drugs, how much will you give this drugs, when will you give this drug, how will you measure this. Now these are the checking questions. For feeding also, we have to give advice that what food has to be continued. Generally this has been seen particularly in India, many mothers, they stop giving feeds to the baby when child becomes sick. That is a process which must be discouraged. Now at one more thing which I just forgot to tell, I am adding, if mother is doing something wrong, Please do not point out in such a way that mother feels guilty. It has to be improved, it has to be corrected. So that improvement has to be done, and checking question has to be done before mother leaves your clinic or health center.
Now we will go to the IMCI approach proper. As you are already told, there are two age groups, that is 0 to 2 months and 2 months to 5 years. Today we will be discussing from 2 months to 5 years, that is the older child, and in this age group we will be discussing about how to assess the child, then how to classify the illness, how to identify treatment, and how to treat the child. Now I will request Dr. Chelani to take up the issue of general danger sign.
A child who is not completed yet 5 years, then that is included in 2 months up to 5 years, and a child who is exactly 2 months, that will be covered into this group. So a child who has not completed 2 months will be covered in a group 0 to 2 months age group chart actually. And as it has been said, though in the traditionally we have been talking about the history and examination, same way here what we are doing is assessing and then classifying and then identifying the treatment. So in this older child, there are few questions which we ask the mother, and then we assess the baby to find out whether this baby needs an urgent referral to the hospital or not. So that is what they said, assess the child for general danger sign. And if you see on the page 5 of the chart booklet, we are asking 3 questions, and the first question is the child able to drink or breastfeed? A child who is not able to drink or breastfeed, he is a sick child, and this child requires an urgent referral to the hospital. Second, does the child vomit everything? Here we ask the mother about vomiting, and now please remember that here we should understand the difference between recurrent vomiting and vomiting everything. A child who is vomiting each and everything, that is a danger sign, and we need to again refer this child for assessment. What is the cause? Is it the intracranial pathology, it is severe gastroenteritis, or some abdominal distension for which the baby is not retaining, for which the baby requires an urgent referral. Now in this we have to ask in the language which the mother understands, because many a times when we put the word convulsion, she may not understand. They may be using the simple terms as fits or some spasm or stiffening of the body. So ask the mother in the language she understands about the history of convulsion. Though we know in our undergraduate or postgraduate there are different grades of the unconsciousness, from drowsiness, lethargy to deep coma, but here from the action point of view, a child who is lethargic or child who is unconscious requires the same kind of attention, that is the referral to the hospital. Now how do we say that this child is lethargic? That means the child who is normally supposed to be awake, but you find the child is not awake at that particular moment, is labeled as lethargy or unconsciousness. Now have a video of assessment of a child with general danger sign.
First, she checks for general danger signs.
A general danger sign means that a child has a serious condition. This condition may require immediate life-saving attention, such as antibiotics by injection, oxygen, and other medicines which may not be available at the clinic. Therefore, a child with a general danger sign may need to be referred to hospital.
To check for general danger signs, first ask,
is the child able to drink or breastfeed? A child is not able to drink or breastfeed if the child is not able to drink at all. This child is not able to drink. A child not able to drink or breastfeed includes the child who is too weak to suck or swallow. This child is not able to drink. A breastfeeding child may have difficulty sucking when his nose is blocked. However, The child can continue to breastfeed when the nose is cleared.
Ask,
Does the child vomit everything? If the child tries to drink but repeatedly vomits and is not able to keep anything down, the danger sign is present.
next ask,
Has the child had convulsions?
a child with convulsions during this illness is not likely to be actually suffering from them when you see the child. Ask the mother if the child has had convulsions during this illness. Use terms she will understand. The mother may describe convulsions using words such as fits or spasms. If a mother reports convulsions during this illness, the general danger sign is present. Next, the health worker looks to see if the child is lethargic or unconscious.
A lethargic child is drowsy when the child should be awake and alert. The child will not look at the mother or watch your face when you talk. This child is lethargic. This child is lethargic.
I think the interesting finding in her is her inability to make eye contact. Juliana, can you try and get
The child may fail to waken when the mother talks or when you clap your hands.
She's not following Juliana.
Even a very young baby who sleeps a lot should respond to these sounds. If the child does not respond to clapping, shake the child gently.
Does not make eye contact.
An unconscious child cannot be wakened. He does not respond when he is spoken to or shaken. This child is unconscious. If the child is lethargic or unconscious, the general danger sign is present.
If any general danger sign is present, you should complete the rest of the assessment immediately, so there will be no delay in the child's treatment.
So you have seen that actually that a child who is lethargic, that means he is not responding to the environment. His eyes may be open, but he is not, if responding to the environment or surroundings, that means he is a lethargic or unconscious child, and such a child requires an urgent admission to the hospital. Now there are four main symptoms for which the child is assessed, and the first of them is the child with the cough or difficult breathing. Now in this we ask the mother, does the child have cough or difficult breathing, and if the mother says yes, then we ask for how long this cough is present, and then after asking this we are assessing the breath rate of this baby, and we are also looking for the chest indrawing, we are also listening for the stridor. Now please remember that these things, the counting the breath rate, the looking for the chest indrawing or listening for the stridor, this you have to do it when the child is calm. If the baby is crying, it will affect the breath rate. Similarly, if the baby is crying, you will not be able to hear the proper sounds, the stridor. So you may be mistaking the sounds which the baby is having. So shall we have this now assessment of the child for cough or difficult breathing?
After checking for general danger signs, continue the assessment by asking about the first main symptom. Ask,
Does the child have cough or difficult breathing?
if the mother replies yes, assess the child further.
A child with cough may have pneumonia or another severe acute respiratory infection. You must be able to identify the few children with pneumonia among the many children with coughs or colds.
If the child has a cough or difficult breathing, ask,
For how long? It's important to know how long a child has been coughing, as a chronic cough, lasting for more than 30 days, may be a sign of tuberculosis, asthma, or whooping cough.
Determining whether a child has fast breathing is an important step in assessing a child with cough. Fast breathing is a sign of pneumonia. Count the number of breaths the child takes in 1 minute.
When a child develops pneumonia, the lungs become stiff, making it more difficult to breathe. The child's breathing rate increases as the child's body tries to make up for lung stiffness and low oxygen. Because children's breathing rates slow down as they get older, the child's age must be taken into consideration when deciding whether fast breathing is present.
To decide whether a child has fast breathing, you will count the number of breaths the child takes in 1 minute and compare it with the following cut-off rates. If the child is age 2 months up to 12 months, the child has fast breathing if you count 50 breaths per minute or more. If the child is age 12 months up to 5 years, the child has fast breathing if you count 40 breaths per minute or more. The child who is exactly 12 months old has fast breathing if you counted 40 breaths per minute or more.
We will now watch while the health worker counts the number of breaths this 7-month-old child takes in 1 minute. Look for the breathing movement anywhere on the child's chest or abdomen. If you are not able to see this movement easily, ask the mother to lift the child's shirt. The child should be calm when you watch the child's breathing. If the child starts to cry or becomes upset, ask the mother to calm the child again before counting. The health worker is now ready to start counting the number of breaths in 1 minute. You may practice counting with her. We'll tell you when to start and stop counting. Select an area on the child's chest where you can see breathing movement. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? The health worker counted 90 breaths per minute. Since the child is 7 months old, he does have fast breathing.
Look for chest in drawing.
This child has chest in drawing.
Next, look and listen for stridor. Stridor is a harsh noise made when the child is breathing in. It sounds like this.
Look to see when the child is breathing in. And then, since the noise may be difficult to hear, listen for stridor by placing your ear near the child's mouth. Breathing in, breathing in, breathing in. This child has a harsh noise on breathing in. This child has stridor. child has stridor, the child is in danger of a life-threatening airway obstruction. Sometimes you will hear a wet noise if the nose is blocked. Clear the nose and listen again. Or you may hear other noises when the child breathes out, such as wheezing. These are not stridor.
Often, a child who is not very ill will have stridor only when the child is crying or upset. So be sure to look and listen for stridor only when the child is calm. That completes the assessment for cough or difficult breathing.
So I will request Dr. Prasad to give the tips on respiratory problems.
Well, in the beginning, Dr. Jaina said and requested all the viewers that if you are having your chart booklet with you, please keep it open. Now, that chart booklet is very crucial and very essential for this IMCI assessment, classification, identify treatment, and for everything. Now, so far we have discussed two boxes. One box was for general danger sign and the second box for cough and difficult breathing. Well, if you see your chart booklet, you will find that in the general danger sign it is written check. So wherever check is written, it means that is a compulsory box. You have to enter in that box. It means for all children 2 months up to 5 years, you have to check this box, and that is general danger sign. If this is present, please keep it in mind, record it. It will be required for further classification of other symptoms like fever, like cough or difficult breathing. This will be required. Now, the next box was that of cough or difficult breathing, and if you see that the question is, does the child have cough or difficult breathing? If the answer is no, then there is no need of entering in this box. Skip and go to the next symptom, which is diarrhea. But if the answer is yes, then you enter in this box and use your 4 tools which Professor Agarwal told: ask, look, listen and feel. And because of depending on these tools, you get certain signs, and depending on these signs, you are making a classification. So now you have seen the video, how to look for these signs, how to count the breath, how to look for chest in drawing, and how to look and listen for the stridor. Now you got some signs. Now it is appropriate time to make a classification. So now I will request Dr. Chelani, please show to the viewers that how do we classify this cough or difficult breathing.
Thank you, Dr. Prasad. We have assessed the child for cough or difficult breathing, and we have counted the breath rate. We have seen for the chest in drawing, and we have looked and listened for the stridor. Now, on basis of these 3, we will be classifying the illness. Now, how do we classify? If you see these boxes, these charts which you are seeing, first chart, the second or third chart, they have got 3 color combinations, that is red, yellow and green, just like the traffic light signals. Now, red means the child requires an urgent referral to the hospital. The yellow boxes means that a child requires a treatment with some antibiotics which the mother can give at home. The green box means an classification for which the mother can use the home based remedies. So, going for the classification now, if you see the signs which we have assessed, if we see on the top row any general danger sign or chest in drawing or stridor in a calm child places the child into classification of severe pneumonia or very severe disease. a child who does not have any general danger sign, chest indrawing or stridor, we go to the next sign, fast breathing. Classification is pneumonia. A child who does not have any of the sign of the red or yellow box places him into the classification of no pneumonia, that is cough or cold. Now please remember, when you are classifying the illness, you always start from top and then come to the bottom. You always start from the red box and then go on to the yellow box. A child may have a sign from both these boxes. Child may have a sign in the red box and the yellow box, but our classification will be of the red box. I am giving an example. A child may have chest indrawing and also has got fast breathing, which is quite common in a child with pneumonia. But here a child who has got a chest indrawing will be classified as severe pneumonia or very severe disease. That is what the classification will be made. So we have got here three classification, and child will have either severe pneumonia or very severe disease, or pneumonia or cough or cold. That's how we classify a child with cough or difficult breathing.
Thank you, Dr. Chalani, for explaining the classification. As you have viewed the classification not only for respiratory problem, for all the problems that we are covering in IMCI, you will be classifying into three categories. If it is a severe category requiring referral, it will fall in the pink box. If it is a case which can be managed in the outdoor with intervention of the doctor on an outdoor basis, then it will be yellow box. If it can be managed absolutely at home, then it is in the green box. So you have seen the classification of the respiratory problems. Now I will request Dr. Chalani to give an example and how the students will be filling up the form, because this is what you observed in the patient. Now you verified in the chart book that okay, this child falls in this category. Then you will be proceeding to next box. Now how to fill up these findings, how to record these findings so that you can come to a conclusion ultimately. That is the process, we call it that recording form. So there is a recording form for the older child, there is a recording form for the young infant. Young infant we mean below 2 months. So I will request Dr. Chalani to show the example of the proforma for 2 months to 5 years and carry up.
With the way we write down the information on the prescription slips, similar in this strategy of IMNCI, that is Integrated Management of Neonatal Childhood Illness, we record the information on this recording form. And as Dr. Jana has said, please use the appropriate recording form, and that is what you can see here. It is written management of sick child age 2 months up to 5 years, because the recording form of a child age up to 2 months is different from the one which you are using for the age from 2 months up to 5 years. And this assessment, this is the front portion of the recording form, where we are making our assessment and we are making the classification. On the back of this recording form is the where we will be writing the treatment of the child. So that we will be discussing little later. So first, if you see, we are having the columns of name, age, weight, temperature. That is, now wherever you are finding the place gap which is written, the space which is there, you will be writing down the information. For example, child's name is Ajay, so the name will be written Ajay. Age will be written in months. So for age 2 months up to 5 years, all the children's the age will be written in months. Then weight will be recorded in kilogram and temperature will be written in centigrade. Then ask what are the child's complaints. So mother's complaints will be written here, and to say this is an initial visit or follow-up visit, we will make a tick mark. So here we are in this we are not writing yes or no, we are putting it mark tick. That means, so just to make a uniformity so that everybody follows the same process, that's what we are using it here. So here we are putting a tick. Similarly, if we are saying check for general danger sign, if these general danger signs are there, then you will tick mark yes. That's what we are mentioning. Now coming to the next actually box is that is the child who has got cough or difficult breathing, answer is yes or no, so you will tick mark in yes if it is there. For how long? Then you will be putting it for, let us say, 3 days. Now out of this, the sign which is present in a particular child, a child who has got a fast breathing, that will be encircled. So please remember, now we are having now information like a sign which is present, generally we write yes or no. Here we are encircling. Encircling means a particular sign is present. If I am not encircling the chest in drawing, that means that particular sign is not present in that child. And the space which you are finding, like count the breaths in 1 minute, so space is mentioned, so you write down the breaths which you have counted. For example, a child of 6 months, if I have counted 52 breaths, so I will write down here 52 and that I will be encircling. Same process I will be following for the child with diarrhea, for fever, for ear problem and malnutrition. Now here is a difference in the immunization column. The child who has received a particular vaccine is tick marked, but the vaccine which is required today will be encircled. So suppose a child who is 6-month-old baby and he has received the DPT, he has received the first dose of the DPT, but who has not received the second dose of DPT and which is due today, so we will encircle here. So 3 things you have to remember: encircling, making the tick mark and filling up the information in the space which is provided here. For example, 3 days, age, weight is recorded, so this is how we have to fill up in the recording form. Then once you have this information available with you, you consult the chart booklet and fill up in the recording in the classification box, the classification which the particular child has got.
There are 3 procedures. Number 1, if there is a blank, you will write something. It may be the complaint of the mother, it may be number of days, or it may be some other like the weight, you will come later on. So all those things can be written. If a finding is present which you have elicited, you will circle it, and if it is yes or no, then you tick mark it. So these are the 3 things you are doing in the form, and it is a uniform procedure which will be done by all the students throughout the country, and in the same process you will be coming to the next boxes. Now we have covered 2 boxes. The first box was general danger sign, the next box was respiratory problems. Please note, if you are entering a box, first you will tick mark yes or no. If it is no, you don't enter the box, you skip that. For example, respiratory problem, the mother tells no, there is no cough or difficult breathing, then you do not enter the box, you will put a tick mark on no. So no is ticked and you skip the box, you go to diarrhea. So the next box is diarrhea. So now we will be discussing that how to approach a child with diarrhea, where mother tells yes, there is a problem with diarrhea.
First question definitely is that, does the child have diarrhea? If mother says no, then no need of entering in this box, go to the next complaint. But if mother says yes, then enter in this box and ask. Again you are utilizing those 3 tools here: ask, look and feel. Listen is not required here, but 3 tools you require here: ask, look and feel. So you are asking 2 questions. First, for how long, and second, is there blood in the stool? You will find out the significance later on when we come for the classification. After asking this question, we are looking and feeling for the general condition. 1, whether the child is lethargic or unconscious, which you have seen in the general danger sign also, or child is restless or irritable. Next point, we look for the sunken eyes. Then we offer some fluid to the child and see the reaction, how the child is drinking. Is he drinking normally? Is he drinking very eagerly and he appears to be thirsty, or he is not able to drink at all, or he is drinking very poorly? And last thing is that we pinch the skin of the abdomen of the baby, and that we will be showing you in the video how to pinch the skin, and we see whether it goes back slowly or very slowly, and very slowly means taking more than 2 seconds. So if these signs are present, then depending on these signs we have to classify first the dehydration, then if diarrhea is 14 days or more, or if there is blood in the stool.
To assess for the main symptom of diarrhea, ask,
Does the child have diarrhea?
if the mother says yes, assess the child further. Ask,
For how long?
the number of days determines whether the child has persistent diarrhea. Next ask,
Is there blood in the stool?
blood in the stool is a sign of dysentery. Then every child with diarrhea is assessed for signs of dehydration. To assess a child for dehydration, look at the child's general condition. Decide, is the child lethargic or unconscious? Is the child restless and irritable? You will now see examples of these signs.
This child is very ill. His general condition could be described as unconscious. This child's condition could best be described as restless and irritable. This child appears well and alert. He is attentive and interested in what is going on around him. He is not lethargic. He is not restless or irritable.
Look at the child's eyes.
This child's eyes are definitely sunken. This child has eyes which are sunken. If you're not sure if a child's eyes are sunken, you should ask the mother whether the child's eyes look unusual to her. This child's eyes appear normal. They are not sunken.
Offer the child fluid. Is the child not able to drink, or drinking poorly? Is he drinking eagerly, thirsty, or does he drink normally?
This child is not able to drink at all. This child is obviously thirsty and drinks eagerly. Often the thirsty child grabs for the spoon or cup. This child is drinking normally. He is not thirsty.
Pinch the skin of the abdomen. Does it go back very slowly, taking longer than 2 seconds? Does it go back slowly, or does it go back immediately? To correctly assess dehydration, consider each of these signs and use them to classify the child as having severe dehydration, some dehydration, or no dehydration. Now, let's assess this child with diarrhea. The mother has told us this child has diarrhea.
For how long?
She replies, for 3 days.
Is there blood in the stool?
There is no blood in the stool. His general condition could be described as restless and irritable if the child remains like this throughout the assessment. His eyes appear sunken. When offered a drink, he drinks eagerly. He is clearly very thirsty. When his skin is pinched, it goes back into place slowly. Now, let's see how the child's signs relate to the classification chart. Start with the top, pink row. He is not lethargic or unconscious. His eyes are sunken. He does not have the sign not able to drink or drinking poorly. His skin pinch does not go back very slowly. To classify the child as severely dehydrated requires two signs in this row. This child has only one. So we move down to the middle row. Does the child have two or more of the signs needed to classify him as having some dehydration? His general condition is restless and irritable. His eyes are sunken. He is thirsty and drinks eagerly. His skin went back slowly. This child has more than two signs of some dehydration. Therefore, this child is classified as diarrhea with some dehydration. He does not have persistent diarrhea or dysentery.
Well, one word about the skin pinch. Well, whole skin thickness is taken into the pinch, and the pinch is done at a longitudinal line. Longitudinal line means that line which is parallel to the length of the baby on the abdomen, and that line should be between umbilicus and the flank of the baby. So that point was shown in the example and how they classified. So these points, it is very simple. Previously in PG teachings and undergraduate teachings also many things were added, like see the mucous membrane of the mouth, see the tears, ask for the urinary output. Yes, those are important, but these four things have been thoroughly studied and found to be having high specificity and sensitivity. Well, there are certain fallacies in those signs, like if we look for the mucous membrane of the mouth, even if the baby is severely dehydrated and mother has given some fluid in the mouth, you will find that it is wet. So that is some fallacy. That's why those signs have not been taken into account. These four signs, they are very, very important, which help in classification. And so far as classification, Dr. Chelani will add more about the classification, but I tell one thing, whether it is diarrhea or persistent diarrhea or dysentery, the classification for dehydration is a must.
There are some differences which we will talk about, but first we will see how we classify a case of diarrhea. As Dr. Prasad mentioned, every child of a diarrhea will be assessed for a dehydration, and we are seeing in this box there are three boxes, red, yellow or green. So a child has to have at least one box. Either the baby will have a severe dehydration, or the baby will have some dehydration, or no dehydration. So one classification will be there. So if we see from here, classify diarrhea for dehydration, we have to have, again starting from red and then going down, two of the following signs. So there are four signs mentioned, and to satisfy the classification of severe dehydration we have to have two signs. Please remember, in the cough or difficult breathing we used to have one sign when we can make the classification. Here we have to have two signs, then only we will make the classification of severe dehydration. Please remember, Dr. Prasad said that these signs, if we use in combination, they are having a very high sensitivity and specificity. Like a severe malnourished child may have sunken eye. So if we take only one sign, that will not satisfy the classification of severe dehydration. We have to have minimum two signs to put it into severe dehydration. So after that we going to the some dehydration. In this, restless or irritable, sunken eyes, drinking eagerly and skin pinch going back slowly. Now here it was skin pinch going back very slowly. Now how to differentiate very slowly from a slowly skin pinch? Now that's what we say, that if you pinch the skin and if it returns to normal within 2 seconds, then it is called going back slowly. But if it takes longer time, more than 2 seconds, then we call it going back very slowly. Now we are not looking at the watch how to find out very slowly or slowly. So very simple thing, if we say that 42 and 43, this roughly takes the time of a more than 2 seconds. So that's how we, if you count in your mouth that 42 and 43 and that you see that skin pinch is still persisting, that means it is taking more than 2 seconds. That's how we differentiate. And then if there are not enough signs to classify the some or severe classification, then we call it a no dehydration. Now this is a conditional, that means if the diarrhea is more than 14 days, then only you will classify into either severe persistent diarrhea or persistent diarrhea. So that means if the dehydration is present, our classification will be severe persistent diarrhea. If no dehydration and the diarrhea is just more than 14 days, we will call it a persistent diarrhea. Then going back further, that if there is a blood in the stool, then this will be classified into dysentery. In this box the child may have 1 classification, may have 2 classification, or may have 3 classification in the box of diarrhea or dehydration, whereas in the cough or difficult breathing there is only 1 classification. You needed 1 sign to classify, here you need 2 signs minimum to classify into some or severe or no dehydration.
Thank you, Dr. Salani. I think Dr. Salani made a point very clear, that in respiratory problem, when you enter a box, there is only 1 classification, that is either very severe pneumonia or cough or cold. But in case of diarrhea, once you enter the box, if mother tells yes there is diarrhea, you enter the box and you assess the child, then you may have only 1 classification, you may have 2 classifications, or you may have 3 classifications. 1 classification will be related to dehydration, whether there is severe dehydration or some mild dehydration or no dehydration. Another classification could be, if the duration is more than 14 days, then it could be persistent diarrhea, and if there is blood in the stool, it could be dysentery. So depending upon the associated complaints, you may have 3 classifications or 2 classifications or 1 classification in the box of diarrhea. Another thing is, for picking up a classification, you should satisfy of 2 findings. If there are 2 findings, then you pick up that box. But please note, if there is 1 finding in the yellow box and another finding in the red box, then the finding will be taken from the red box, because red box gets the priority over the yellow box. Similarly, if there is 1 finding from the yellow box and another from the green box, then it will be taken as yellow box. And if there is only 1 findings, irrespective of the box, even in the red box there is only 1 finding, then it is not sufficient to classify there, therefore it will be green box. Please note this point, otherwise you will be making a classification mistake. Okay, Dr. Chalani, we used a sign that is lethargy, but do you mean lethargy and unconsciousness? How you distinguish between that?
In this IMCI, from the action point of view, because this strategy is an action oriented strategy, we don't want to differentiate the lethargy or unconsciousness, because for us both these entities, they require the referral actually, and this is a general danger signs and which requires. So the treatment will remain the same whether it is a lethargy or unconsciousness. Yes, the prognosis might be different actually, that's what we see later on, those children who are meningitis who have got lethargy, or those children who are having a deep coma actually, that's a different thing. But here that we are not trying to differentiate, here we are trying to take this sign as 1 sign and we are clubbing it and saying it that this child requires a referral to the hospital.
The next box in our series will be fever. So first you assess general danger sign, then you assess for respiratory problem, then diarrhea, and then fever. So this is a sequence we follow, and this is the sequence you will find in the proforma.
Classification has got its own significance. A certain set or subsets of signs and symptoms clubbed together make 1 classification, and the idea of saying classification is the action which we are intending to take on that classification. So, as Dr. Chelani has said, that this IMCI program is an action-oriented program, and that's why we are using the term classification. So, the first question definitely is, does the child has fever? And we enter in this box only when there is answer yes. And now there are three ways for the answering yes. One, by history, if mother says that the child is having fever, then we say that fever is present. Or if we feel the baby and baby is hot to touch, then we say that fever is present. Or we actually measure the temperature by putting thermometer in axilla for 3 minutes. So if we find that the temperature recorded is 37.5 degrees Celsius or more, then in either of these conditions, any one of present, we say that fever is present. And if it is present, then we are asking, we are deciding first whether it is high malaria risk or low malaria risk or no malaria risk. So, and if patient is belonging to low or no malaria risk, then we are asking a question whether the patient has travelled to an area which is known for the high malaria risk. That is the question that must ask. And if fever is present, we are asking for how long it is present. If more than 7 days, is it coming every day? Is the fever present every day? And third question we are asking, that is there any history of measles within last 3 months or now? That we have to decide. And once we have asked this question, we have got another tools, look and feel. What do we look for? We look or feel for the stiff neck is the first thing. We look and feel for the bulging fontanelle the second thing. We look for the runny nose is the third thing. This we are doing, and in this box there are other things also. There we enter only when we decide that there is measles now or was within last 3 months. In that case, we look for the generalized rash and any one of these three: cough, runny nose or red eyes.
Assess every child for fever whose mother gives a history of fever during this illness, or who feels hot, or who has a temperature of 37.5 or higher. Ask,
Does the child have fever?
it is important to make sure that the mother understands what fever is. Use a local term for fever, or ask the mother whether the child's body has felt hot to her. A child may not be suffering from fever at the time when it is brought before you. However, it is important to know if the child has had fever with this illness.
Fever is assessed because fever in a sick child can be a sign of serious illness, such as malaria or measles. If you do not have a thermometer, feel for fever. Feel the child's stomach or under the child's arm and determine if it feels hot.
Assessing a child for signs related to fever is a two-step process. The child is first assessed for signs of malaria and for measles, and then, if measles is present, for signs indicating complications of measles. First decide the malaria risk. Is there a high or low risk of malaria? Then ask,
For how long?
if the fever has been present for more than 7 days, ask,
Has fever been present every day?
ask,
Has the child had measles in the last 3 months?
next, look or feel for stiff neck.
It's important to assess a child with fever for stiff neck because the child may have meningitis.
First, watch to see if the child bends his neck while looking around. If he does this spontaneously, he does not have a stiff neck. If he does not bend his neck when looking around, Encourage the child to bend his neck by drawing his attention to his toes. This is generally more effective than trying to bend the neck with your hand, since many children will automatically respond by tightening their neck muscles.
If the child can look down, almost touching his chin to his chest, there is no stiff neck. If you are not successful in getting the child to bend its neck, you should slowly, gently, put your hand behind the child's head and try to bend the neck. The neck should move easily.
Look and feel for bulging fontanelle. This sign can be assessed only in children who have an open fontanelle. The fontanelle closes in most children by 18 months of age.
Next, look for a runny nose.
A runny nose in a child with a fever may indicate a cold. In a low malaria risk setting, observing whether a child has a runny nose helps to distinguish whether the fever is due to malaria or a cold.
Look to see if there are signs suggesting measles. Look for a generalized rash.
In measles, a red rash begins behind the ears and on the neck. It then becomes generalized. That is, the rash spreads to the face and body. Then the arms and legs. A generalized rash like measles covers the whole body. It should not be confused with a rash like scabies, which is usually found on the arms and stomach. Nor does measles appear just as a rash only on the face or on the scalp.
A child with measles will also have one or more of these three signs. A cough, a runny nose, or red eyes. If the child has measles, move on to the second part of the fever assessment. When a child has the signs of measles, it is important to continue assessing the child for signs of eye or mouth complications. Look for mouth ulcers. Are they deep and extensive? Look inside the mouth for mouth ulcers. This child doesn't have mouth ulcers.
But this child does. These are painful open sores on the inside of the mouth, lips and tongue. They may be red or have a white coating on them. Mouth ulcers make it difficult for the child to drink or eat.
Next, look for pus draining from the eye.
This child has pus. Measles can be complicated by an infection of the conjunctiva, or white part of the eye. This can be identified by the pus which collects in the eye.
Look for pus on the conjunctiva, or eyelids, or draining from the eye. Next, look carefully for clouding of the cornea.
The normal cornea is bright and transparent. Through it, the iris and the round pupil at its middle can be seen. A normal cornea allows you to see the color of the iris clearly. The pupil is black, Measles can cause a white spot or clouding to appear in this part of the eye. The clouding may occur in only one or both eyes. When exposed to light, the condition may cause irritation and pain, and the child keeps the eyes tightly shut. Corneal clouding can progress to bad ulceration of the cornea like this, which can result in blindness.
That completes the assessment process for fever.
You have already seen that how we assess the fever. Now we will have the further discussion on fever and other boxes. Thank you for viewing these things, and we will be, please stay with us when we meet again. Thank you all.